Good afternoon, everyone. I am Dr. Elvira Bisbe. I am anesthesiology and I work in Hospital del Mar in Barcelona. I lead a program that is called MAP project that helps hospitals to develop or implement PVM programs. It's a pleasure for me to be in this exciting congress that for clinicians like me, it represents a novel approach to treat our topic, patient blood management. We believe that is the ideal forum to discuss about PVM, since as you will see, despite being clearly a triply aimed strategy and having the support and also the impulse of the WHO, we are far from the sufficient implementation of PVM in the hospitals. Surely because it's not enough to have the clinicians convinced, since the scope of the change in health organization clearly requires the involvement also of the managers and the directors of the hospitals, and as well of the health authorities. For this we have experts. There are world experts in PVM, Professor Arizanda and Professor Axel Hoffman. Professor Arizanda is the Emeritus Chief of Department of Anesthesiology and Critical Care in the Inglewood Hospitals in New Jersey, and it's also Clinical Professor of Anesthesiology, Medicine, and Surgery in medical schools in New York and New Jersey. And Axel Hoffman is a health economist and professor on health and medical science in the Division of Surgery in the University of Western Australia and also in the University Hospital of Zurich. So both lead 10 or more than 10 years ago, the change in the paradigm of blood-saving techniques that are focused on the treatment in transfusion and move to focus in the disease, in anemia, and in the patient blood management. And I think that with these talks that we are going to start explaining for you what is patient blood management and which are the advantages of this strategy, and also which are the cost saving that we can get with this type of a strategy. I'm going to explain at the end the experience of the MAP project in Spain that in these 6 years involved almost 60 hospitals in Spain. This is a project that helped for the implementation. So we start with a presentation of Professor Arizanda, if you want to go.
Thank you so much, Elvira, for this wonderful introduction. Again, good afternoon, everyone. I want to thank you, Elvira, for inviting me to speak here this afternoon, as well as a sponsor of V4 and all the individuals who worked very hard to get us and set this up. So I'm here this morning to give the 30,000 meters overview of patient blood management, but we decided to give it a title, which is the added value of patient blood management in terms of outcome and patient safety. What I'd like to do is give you the overview of my talk, which is going to be patient blood management defined as, again, talk about the definitions of patient blood management. I think the change here is looking in terms of the paradigm versus the status quo. Then we'll move on to value, which is outcome-based care versus volume. We heard many talks, I guess, in this conference trying to define volume versus value. I don't need the slides, it's okay. I could tell you a story which you'll find interesting. Then we'll talk about patient safety. And I think that we use the term patient safety, but what is it really, or where does it come from, and what does it really mean? And we'll also talk about if you don't address patient safety, what are some of the consequences? And then, of course, the best clinical practice in terms of putting everything together, rather than looking, again, at what it is that we're using in terms of volume. We're looking in terms of outcomes, which again is best clinical practice. And then I'll finish with showing you that patient blood management, again, covers patient safety, lower costs, and better outcomes with a quick summary. So these are two of the definitions from, again, the two organizations that look at patient blood management from the point of the patient rather than the point of blood products. And it's important for us to understand that there is a paradigm shift from the status quo today, which is transfusion medicine, which I will address with you shortly, to, again, being a patient-centered approach, including safety and value, which we'll address later on. And very quickly, patient blood management is the timely application of evidence-based medical and surgical concepts designed to manage anemia, optimize hemostasis, and minimize blood loss in order to improve patient outcome. Not one word about transfusion. It is all about the disease management that we're addressing here. And the same goes from IFPBM. Patient blood management is an evidence-based bundle of care to optimize medical and surgical patient outcomes by clinically managing and preserving the patient's own blood. Again, moving away from product-based to patient-based. So you could see this is patient-focused, it's a medical condition, or a disease focus. And today, many clinicians use blood because of a number the patient has, rather than identifying the cause of their underlying anemia. Now, the problem is that there are other organizations, especially blood organizations, which have looked at patient blood management in terms of added value and have taken it and defined it in their own ways. And although you may not be able to see that, you may not be able to see that in the back. Here, again, they're talking about involving patients in making the best decisions when it comes to transfusion. That is not what patient blood management is, and therefore they use the mantra, but it's really not centered on the patient. One of the important parts that we've added to patient blood management over time is the patient-centered decision-making. And here again, we need to have the patient involved. We heard a lot about patient satisfaction in some of the other talks, but it's important to get the patient involved because they see outcome in a very different way than we see it. So again, just to emphasize this, we need to explore treatments and provide the patient with a menu of treatments rather than a single one. Again, we have to inform the patients in terms of both benefits and risks, integrate the patient values and their autonomy to the decision making. They may have other issues, not just in terms of survival, but maybe quality of life. We heard about breast cancer before, about some people think that preserving the breast is more important, whereas some women feel that actually having the cancer removed is much more important. And of course, we need to document all these in terms of preferences for patients. However, when you talk about patient blood management, everything comes together when we can demonstrate improved patient outcomes. Now, these are words. We need to actually show that we can do that, and I'll address that as we move on. So the current status quo is with transfusion. And why do we need a paradigm change is the big question. And we need a paradigm change because you could see preoperative red cell transfusion harmful or beneficial to patients. Conclusion here that there's a lot more harm than there is benefit. And that's corroborated with other issues. One of them, which is overuse of transfusion by many clinicians, because they actually don't have a scientific way of addressing transfusion, except for a number. Again, we're not treating the underlying disease, we are treating a number. And here you could see that overuse, as defined by the Institute of Medicine today, it's the Academy of Medicine. Back in 1980, it was the use of health services in circumstances where the likelihood of benefit is negligible, and therefore the patient faces only the risk of harm. Let me just say this emphatically, that transfusion fit into into this sentence in a well, they fit very well. So again, we know that there's data out there showing that transfusion is overused, meaning there's no benefit, only risk to the patient. This is why overuse is not just for transfusion, but also other medical intervention. But you could see as high as 83% in some institutions, 77% in others, and 85% when it comes to plasma. So we could see, again, as we look at different components of blood, that there is enormous amount of overuse, meaning, again, risk to patient, no benefit. Now, this is compounded for another problem. This other problem has to do with the variability of transfusion, meaning it's not the same from one institution to the other and is not the same from one practitioner to the other. This looks at almost 800 hospitals in the United States. This is coronary artery bypass grafting, and you could see that some hospital you get blood as you come in the door, 100%, and others are less than 20% transfusion, same surgery, same blood loss. Now everybody says, well, I had to give them transfusion because they were sicker, without any evidence that they're going to get any better, but still that is used as a reason for the high transfusion. But all studies that looked at variability come up with the same conclusion, that variation in transfusion rate is not due to differences in patient acuity, and again, it's due what you see in yellow, which are all modifiable risks in terms of using transfusion as a therapeutic intervention. Now, the WHO in 2011 came out with a statement that shows that recent studies in many clinical settings have shown that the potential short and long-term hazards of transfusion have been underestimated, and other randomized studies have failed to show benefit of red cell transfusion. I'm showing you over and over again why the status quo needs a new paradigm. We can't be doing the same thing over and over and expect different results. So again, this is the list, and you probably can't see this in the back. Maybe I can highlight some of that, but I can't. Knowing the negative outcomes of blood transfusions, and it goes anywhere from infection to increased mortality, which is the end. And you ask yourself, with all of this, why is it that there's no black box warning? I will tell you, and I'm not speaking pharma, I could tell you this also for the device industry, that it takes a lot less than what you see on this slide to get a black box warning. So again, you could see that we need some change in the paradigm here to address this issue. And if we didn't have one, again, I would stand here and maybe try to just reduce transfusion, but we need to do more than that. We actually need to look at the underlying condition or disease of the patient and manage that appropriately, because that's what we do in medicine every day. This is another article looking at improved outcomes and reduced costs associated with health system-wide patient blood management program. This was a retrospective observational study in 4 major adult tertiary hospitals, and this comes from Western Australia. And again, here they demonstrated, in addition to the reduction in transfusion, an improvement in their financial status, which I'll get to later on. But again, keep in mind, this is just the side effect of patient blood management, reduced transfusion. We're also, what they were able to show, improved clinical outcome, including mortality, as well as cardiovascular disease and other. So this brings us to the question of value, because we are saying, where is the added value of patient blood management? Well, we know that patient blood management improves quality. Well, we say that. We still have to define quality is. But we already established that it reduced costs. In a sense, then it's improved value of healthcare. So we're talking about these 3 elements in healthcare, which include value, cost, and quality. And again, all that is included already in patient blood management, which is good clinical practice. The problem, as you will hear, is of course the implementation, because transfusion is a strong culture in a hospital. And I'm sure someone has said this in this conference, that again, changing culture. Culture eats strategy for breakfast, lunch, and dinner. I'm sure it's been said here already. So again, we could see that this is U.S. Food and Drug Administration, the FDA, not endorsing it, but just showing you that they've also looked at the shifting from primary goal of compliance, meaning doing things the way we should, the old paradigm, or as I say, the status quo, and moving it to drive industry beyond compliance and quality. Again, we need to go beyond just doing the same thing over and over again, expecting different results, into the new realm, which again requires a culture change. Again, shifting the focus to quality from quantity, again, and looking at stakeholder engagement. The biggest stakeholder of healthcare is not administration, it is not the clinician, it is the patient. And all of us sitting in this audience are potential patients. And when we face healthcare the same as our patients do or the public does, we start learning what it is that we're doing on every day. And believe me, there is a lot of room for change. So again, some of the characteristics of quality, which I mentioned before, because we don't have one sentence defining quality, includes the prevention of disease. It's got to be, again, looking at where we can improve the health of the patients by avoiding diseases. Again, avoidance of complications, and of course, improve survival. But survival alone is not enough. We have to have survival and quality of life both improved. This is the language of patient blood management. So now add an improved quality of life, if you will, into the patient blood management paradigm. Next is the public view, and we heard before about how patients view quality of healthcare. And it says the public defines healthcare quality as including both technical and interpersonal domain. How are you being treated? Patient experience is becoming a major element in terms of measurement today, at least in the United States, and I'm sure it's moving across the globe. Again, however, outcomes and adverse events are also important to patients, but we don't publish those in comparison. Most patients don't look at a chart showing which is the hospital that has the safest practice as compared to a hospital that doesn't. But today we're starting to see hospitals advertise that they're doing patient blood management, and that connotes already higher quality as well as improved inpatient safety. Again, this is the language of patient blood management. And the public views goes on, again, asking whether the patient gets better. This is what people want to know. If I get to a hospital, do I get better or do I get worse? During COVID, we saw a lot of reticence in terms of patients coming to the hospital because they thought that they're not infected, but if they come to the hospital, they may come down with a disease, meaning they're not going to get better, again, by coming in. Do the hospitals and the doctors have the expertise and equipment needed to care for my condition? Well, if you move in to the old status quo, those clinicians don't. It is our position that you need to educate and change that culture into the new paradigm. So that, again, is the language of patient blood management. The public views, as I go on, also states, do patients get the right medications? Does someone explain the purpose and the side effects of new medication? Let me tell you, every clinician in this room knows that when we get consent for transfusion of patients, we tell them there's no HIV, there's no infection risk, sign here. Because many clinicians do not have that. So these are examples of failure, if you will, in terms of moving on to the new paradigm of patient blood management. Again, the strategy for healthcare reform towards a value-based system. This was Porter's publication, which influenced a lot of payment in the United States going back more than a decade now. And again, you could see that previously the system rewarded those who billed for more services. It may be different in different countries, but I know in Spain, as an example, there is more money if you transfuse more. Again, no benefit, only risk, but there is more money. Not those who deliver the value. Can we again demonstrate that value as needed? And a value-based system will provide a reward achieving and maintaining good health versus dealing with poor health and decreasing cost and resource consumption. We're all talking about the same language, if you will, when it comes to patient blood management. So the way forward is, where do we set the bar? We need to be able to have some measures that, and someone mentioned in a previous talk, measures that are, again, have reliability in them, but those measures have to have some tie to financial rewards or penalties. And you could see this in this particular slide. This is trauma and hospital ratio for odd rates for mortality. Those hospitals on the right side are clearly off the chart. You don't want to go there if you have trauma, whereas you do want to go to the left. And again, if this tied financially and becomes transparent, and patients will have possibly a choice, the choice for the patients is always limited geographically, but the choice of having a hospital on the right side is something that we all can work together to change. So the question, of course, is you can have quality improvement by reducing yourself from the right side of the chart I showed before to the left. But how do you hardwire that? We need to make sure that the process of improving quality is transparent, measurable, and hardwired. And Mark Chassin, who was the head of the Joint Commission, I know you have it in Spain, my condolences, but again, their criteria, as he puts it together here, in terms of the important one that I want to show you is the one in the bottom, which is the implementation of measure has little or no chance of inducing unintended adverse consequences. And let me just say this is exactly patient blood management language. We want to show you improved outcome at lower costs, and again, no negative outcome. Now, this is making patient blood management the new norm as experienced by implementers in diverse countries. Unfortunately, again, this was a fairly overly detailed manuscript, but the concept of patient blood management for all is still an essential one. However, you could see that, again, patient safety is number 4 on this list in terms of a driver. Well, it really should not be a driver. It should already exist. Any patient safety activity should be, bottom line, should be existing in an institution rather than measuring any kind of a driver for change. Which brings us to, again, as I mentioned early in my talk, the fact that there are others there who use the mantra, and this is the Institute of Healthcare Improvement, talking about patient blood management through the lens of patient safety. And guess what they're talking about? They do define patient blood management, but then they move back into transfusion. And making transfusion safe is not going to happen. But care of the patient through patient blood management will deliver safety, because we're going to be looking at the underlying condition and the appropriate management. So again, the evidence-based indication for transfusion, that's not going to help us. And it hasn't helped us because we have guidelines published almost yearly since 1998, and nothing has really changed in this particular status quo. We need to change the paradigm. So again, patient safety is very difficult to define. However, I will say this, that patient safety is the cornerstone of high-quality healthcare. Again, words, we need to be able to define this a little better. So the concept emerged from the healthcare quality movement as back as 2004, but again, keep in mind that the concept of patient safety has been around for centuries and not decades, just poorly defined. So they defined it, the Institute of Medicine, as prevention of harm to patients. The emphasis is on healthcare system and not individual. Prevention of errors, learning from errors, building a culture of safety. And already we mentioned that culture is really the bottom line, and that's what we need to change. The AHRQ expanded the concept to, again, freedom from accidental or preventable injuries produced by medical practice. And there are some good examples that we've adopted in terms of this, and it took some time and effort to do that. But VT prophylaxis, preoperative antibiotics, preoperative beta blockers, informed consent verification. Again, we don't do it well in many hospitals, but the fact of the matter that these are positive endpoints, if you will, in terms of patient safety. So again, the NQF, or the National Quality Forum, defined it in terms of the lack of patient safety. What is the cost of not doing it? And here they talk about the care failure with associated negative outcomes. So you're more likely to be in an institution that has a low safety profile and have more complications and negative outcomes than you do in an institution that has a high commitment to patient safety. So this brings us to the conclusion here. This is a programmatic approach to patient blood management, reducing transfusion and improving patient outcome. So reducing transfusion is not the goal of patient blood management. It's improving patient outcome. But on the road, as we talked about, we focus on the implementation process of it that has to be transparent and hardwired. And again, it has to go back to the essential of medicine, which is diagnosing a disease and using appropriate management of the disease with the patient's ideas of how they see their healthcare outcome. Very important point. But as you could see from this article, there is a reduction of transfusion up to 95%. There's mortality reduction of close to 2/3, reduction of length of stay up to 1/3. These are all cost and healthcare measures. Again, reoperation down about 43%. Readmissions to hospital, a major concern for us today, about, again, 43%. And complication, reduction of composite morbidity up to 41%, and reduction of infection rate up to 80%. And lastly is the issue of cost. And you could see there is a tremendous range between 10 and 84%. But let me just say to you that there is inherent cost reduction because we are utilizing resources well, but also reducing unnecessary, as I showed you already, use of resources. So as we approach the summary, patient blood management addresses both quality and safety. It's centered on patient outcome. It's centered also on preventative care. It improves patient safety. There's avoidance of risk, and again, looking mostly at what's beneficial for patient, reduces resource utilization, provides value-based care. We reduce unnecessary procedures. Nobody wants to have unnecessary procedures performed on them. They only want appropriate intervention. And lastly, again, it provides value-based care and is defined as best clinical practice. So with that, I will thank you for both the invitation and your time. We'll take questions at the end.
Yeah. Thank you very much for your nice talk. And now it's the turn for Axel. We are going to talk about the cost.
Well, thank you for the organizers to invite me, and thank you for this great opportunity to talk about massive cost reductions with patient blood management while improving quality of care. In fact, we are talking not millions, but billions of dollars that could be saved. It doesn't work.
You have to focus there?
Yeah, I see that.
Okay.
No, it does. Massive cost reductions is something that I guess you're very interested in, as long as you maintain quality and safety or even improve it. The clicker doesn't work.
You have to pay more, Axel.
Maybe it's on the other side?
Ah, there we go. Try it again.
No.
Working with governmental and public institutions, lab services, professional societies, and industry. What is this?
Next slide, just say next slide.
Can you please?
Just say next slide.
Seems like problem maybe the heat before. We have another mindset. But it's fun, but
Yeah, but it's that's the problem.
And yes, the problem is that that doesn't work.
You'll have to change the slides.
yes.
Okay. No.
Yeah, yes.
One.
Okay.
Thank you.
One moment, it's 2 minutes. Give me 1 minute.
Axel, I didn't do it.
Yeah.
I think we go forward, and if it's,
Yeah.
I have a loud voice if I want, so if you can.
No,
hope
we
you can hear me.
hear, we hear very well.
So I want to start with the health economic challenges of the 21st century. And here's a nice article from the New England Journal of Medicine saying the era of shifting more and more resources towards healthcare is going to end. And also the medicine of the future will focus on more efficient use of resources. Now, what you see here is from the OECD, health expenditures relative to the gross domestic product over years, and you see the highest curve is the United States. There were eras of abundance where over 4 decades, this ratio was increasing, climbing, but then we had the global financial crisis and we had this era of austerity, but now again we have COVID, which drives the cost up again, but nobody knows still how to pay the bill. And we have to understand that these sectors are competing against others like housing, food, education, transportation, you name it. And here's an interesting chart from McKinsey looking at the different sectors of industry, including healthcare. And you can see productivity improvement over almost 20 years. Computers and semiconductors, for instance, were doing very well. But when you look to healthcare, they have a minus in terms of productivity, just followed by construction. So there is a relatively poor performance. And we need productivity improvements. And productivity is defined as output over input, and we have also seen that value is defined as quality over cost. And so here is the real issue. And you've seen, I'm sure you have seen a lot of time, this graph from the Institute for Healthcare Improvement. And what's important is to find to simultaneously pursue what is called the triple aim, improving the patient experience of care, the health of populations, and the per capita cost of that treatment. And the point is innovative ideas, and I think there's a lot of hot air in conferences like this. Let me say it openly and bluntly, because this is all, nice thinking, but where are the tangibles? Where are actually these ideas? What can you do right now when you go back to your hospital? And I think we have to offer you something that Arya Shende has already nicely explained, which is patient blood management. And this is not just an innovation or an innovative idea, this is in fact a disruption. According to Webster's, a disruption is the act or process of disrupting something. A break or interruption in the normal course or continuation of some activity or process. And, what we like to show you now with patient blood management, how it disrupts the normal course of healthcare of the last 60 or 70 years. And you have seen this definition already. The focus is in the outcome, and it's about managing and preserving a patient's own blood, especially when this patient is hospitalized or is an outpatient, for instance, with a hematological or oncological disease. And here are the various societies that have already endorsed it, including the World Health Organization. And here's a brand new policy brief of the WHO, which talks about the urgent need to implement patient blood management. And they show that it's patients, it's pregnant women, but also the population at large that will benefit from it. And it also says that not only the patient will have a win, but also hospitals, healthcare professionals, even health insurance, and the health authorities or public health sector as a whole. And especially for hospitals, this report points out that you will have massively reduced cost for patient blood management, reduced mortality, fewer complications, fewer readmissions, and reduced length of hospital stay. And this is really the 5 key parameters, or key performance indicators that hospital administrators look at and have to look at. And this is again from that study that has already been highlighted, as we implemented this in the state of Western Australia over 6 years with more than 600,000 patients, we saw a decrease in hospital mortality of 28%, almost 1/3 reduction of in-hospital mortality, or nosocomial infection with minus 21%. We all know the nosocomial infection is the demon of hospitals. It is a massive cost burden that can cost up to $35,000 per individual patient. Also a reduction in myocardial infarction, stroke by 31%, and length of hospital stay by minus 15%. We saved the system with the implementation of that program 70,000 stay days. And at the same time, we reduced anemia, and we reduced blood utilization, and we saved them at least $80 million just in direct transfusion costs, not talking of the to be monetarized value of the avoided complications. So this is really a tangible. This is an innovation, and now we want to understand a bit better from the economic perspective why we really can talk of a benefit that saves billions. Let's assume this is your hospital, and let's assume these are 100 surgical inpatients. Now we know from the literature that about 1/3 of these patients are anemic at admission. This is because there is no routine detection of these patients in terms of their anemia, and therefore no correction. And now this is a very important slide here. This is a meta-analysis that looked into about 1 million anemic patients preoperatively. And this study found that 39% of these patients were anemic at admission. And that meant that their outcome was massively in the minus. Perioperative mortality was almost 3 times higher, acute kidney injury about 4 times higher, infection rate about 2 times higher, and there was also a subpopulation of cardiac surgery patients with a significantly increased rate of stroke. And it was the main driver, anemia was the main driver for transfusion. 5 times more likely to be transfused in the hospital being anemic compared to non-anemic. Now, we also know that these patients, or many patients, are made anemic, even when they were admitted. And this is due to a lot of causes. One is excessive phlebotomy rates. And here is a study from Colleen Koch from Cleveland Clinic at the time, who invited 9 other hospitals, cardiac centers, with 190,000 hospitalizations, and the endpoints were mortality, charges, and lengths of stay due to hospital-acquired anemia. And here are the numbers. 77% or 74% of these patients acquired anemia while they were in the hospital, and in terms of lengths of stay and in terms of mortality and charges, there was a steep increase, even with moderate anemia and hospital-acquired, and more so with severe. So we can say already that around 57% of all patients are anemic perisurgically. And nobody really takes care of that anemia, although we have seen what a high risk goes with it. And there's more to it, because about 6 to 12% of these patients are also bleeding moderately to severely during their hospital stay. And now it really gets interesting and important for you as hospital managers and administrators. These few individuals out of 100, they are those who consume basically your entire blood stock. And we know that in a dose-dependent relationship, the more your patients are getting transfused because of a lack of managing anemia and blood loss, the more expensive the patient becomes. We found that the inpatient cost for a transfused patient is about 1.8 times higher compared to the non-transfused after correcting for confounders. We also found that in the Western Australian hospital system, an additional $77 million were just attributable to the transfusion. You can see here, for instance, let's take a hip replacement. Hip replacement without transfusion after adjusting for confounders was about $17,500. With transfusion, $32,000. And so we can have as a rule of thumb that the transfused patient in your institution, in fact in every institution, is your loss leader. This is where you get into the red numbers with the red stuff. And I think this really highlights the magnitude of the problem, what I'm going to show you now. This is a study from 2008 by Morton and colleagues, the first study to assess clinical and health outcomes associated with blood transfusion for the whole of the United States. And to shortcut it, there were 39 million admissions, of which 2.3 million were transfused. And the transfused, again after adjusting for confounders, had a 1.7% higher odds of death, a 1.9 higher odds of infection, 2.5 days more hospital stay, $17,000 more charges, and the study authors encouraged to adopt novel approaches to minimize intraoperative and early post-op bleeding, reduce transfusion requirement, and most important, improve patient-level post-op outcomes in health-related quality of life. If you accrue these numbers across that population in the US and adjust it for 2019 dollars, there were additional charges for that subpopulation of almost $100 billion. And this is why we are saying with patient blood management, by undoing these impacts and these adverse, this adverse impact, you can really improve the life of millions while saving billions. Here's a tabulation of all the adverse outcomes with transfusion that are mentioned in the literature, but Arye has alluded to this already. What I'd like to show, there is more than 6 million patients in all these studies that show a dose-dependent relationship between adverse outcome and transfusion. And there's also randomized controlled trials that look into the impact of less versus more transfusion. And here's a meta-analysis of what probably the most important 3 trials looking at a hemoglobin threshold. That's the hemoglobin concentration that releases a transfusion, so to say, or that makes the surgeon or the physician or the anesthetist giving the transfusion, versus 9 to 10 grams. And so there is no other study on planet Earth that has a larger delta between the two groups. And it showed clearly that it is better to give less. So for decades, blood loss and anemia, for 7 decades, almost 8 decades, the default position was to transfuse these patients. And it is therefore the most common invasive procedure in hospitalizations. And this is something this policy brief of the World Health Organization is addressing, saying there is an unmet need to manage and preserve the patient's own blood so that you don't need to resort to somebody else's, namely donor blood. And it says it's the default therapy, although the data speak clearly against that practice. And therefore, it's time for disruption. It has to end. This culture of adverse outcomes by tolerating blood loss, by tolerating anemia, and tolerating high transfusions has to come to an end. And this is where the principle of patient blood management really kicks in. There's a wonderful rationale behind it, because anemia has not to be accepted as it is. Pillar 1, according to this policy brief, is detect and manage routinely anemia and also iron deficiency as a precursor of the iron deficiency anemia in hospitalized patients and also in outpatients. Pillar 2, minimize blood loss and optimize the coagulation of patients, which has a lot of potential. And finally, leverage the body's own physiological tolerance to cope with lower blood counts in let's say, very extreme situations. And there is successful patient blood management pilot programs around the world. One that I find most impressive is in Beijing, in the Fuwai Hospital, which is the world's largest heart center. They perform 16,000 open heart surgeries a year, so it's a factory, if you like. And you can see on that graph, the dark blue bars are red blood cell transfusions, and the turquoise are plasma transfusions. And you can see how it came down over the years from 70% to about 20% for red cells, and about 65 to 10%, no, is it 10? Yeah, 10% in plasma. And there's at least an abstract in the Lancet showing that when this strategy was instituted in that large institution, or the largest heart center in the world, post-op hospital lengths of stay reduced over 7 years from 10.5 to 7.5 days, and in-hospital mortality dropped from 1.2 to 0.5. We have in Europe, in the United States, in heart surgery, in CABG, the most simple form of heart surgery, a mean mortality rate between 2 and 3%. They managed it with patient blood management, not alone, but with a large contribution to 0.5. Johns Hopkins has introduced a program with an immense return of investment. The first year brought them 400% return of investment. I double-checked the study. There was a flaw in it. In fact, it's 800%. University Hospital in Zurich showed a reduction just for blood products of almost 13 million Swiss francs over 4 years. And you see here major institutions like Mayo, TriHealth, Cleveland Clinic, they all run now patient blood management programs. And here's Jay Bath, one of the executives of the American Hospital Association, saying that improving health and improving quality, the number one thing to do is appropriate management of the patient's own blood. Here is the most modern hospital in Korea. The Annam Hospital is the flagship hospital. And a good friend of Arya and Elvira and myself, Park Jong-hoon, the vice dean of the Korean University and president of that hospital, says he makes it the safest hospital in Korea. Why? Because it's a patient blood management hospital. So not implementing it is absolutely substandard. So the only question is, how do we overcome the barriers of patient blood management? And this is just by creating a sense of urgency for that change. This is why the policy brief says as an urgent need. And the number one element that urges is the evidence, because we have shown you real-world evidence, but there's also case control in cohort studies, there's propensity score match analyses, there are randomized controlled trials on the various therapeutic strategies within patient blood management, and there are meta-analyses showing massively improved outcomes with PBM. The next one is the economics, and I think I have not to go into further detail. Also, Arya has shown already these very impressive and compelling drops in cost factors. And finally, the third E, evidence, economics, and then the ethics. There is an ethical obligation not to ignore and withhold a medical model as patient blood management that is beneficial not only for the society at large, but also for highly vulnerable populations, individual patients, and also blood donors. We shouldn't harvest blood that we don't need. So delaying PBM translates into increased morbidity and mortality, and this is what demonstrates the urgent need for change. So the conclusion, first of all, do everything in your institution when you come back. Get your clinical director and staff together and start with the disruption of a 7-decade-old adverse culture. Implement the new methodology to look after the patient's own blood with the same respect as you would do for any other organ system. Use the 3 E's, evidence and economics and ethics, to get the message across and finally benefit on many levels. So again, this was this wonderful result we had in Australia. We've seen this. PBM reduces mortality and morbidity while saving billions when you extrapolate this to the whole world. According to my quick and dirty calculations, I believe that patient blood management holds a potential of $300 to $400 billion annually on a global perspective. So thank you for your attention.
Thank you for your inspiring talk. I'm going to move So I'm going to start with how to fit this PVM in practice. I don't know if I have to put my presentation or... Yeah, what I do. Okay. So now we understand why it's so important, and how we can get using the patient blood management, and now it's time to say how to make hospitals fit for patient blood management. I'm going to explain a Spanish experience that it's a project that it's called MAP, a Morbidity Assessment Model in Patient Blood Management. And these are my disclosures. And really, we have clear now the benefits. We really know that we can reduce at least 50% of the transfusion. This is what we see in the slides. We can improve the patients. We can reduce the length of stay, and we can save money. So we clearly have a diamond of the health quality. I think it's better than a triple aim project. I think, yes, we can improve health, better care, and reducing the cost, but also we have the possibility to have a social benefit, because we can preserve blood for the patients that really need. And maybe the necessities are different according to the type of the country. In developing countries, it's difficult to get safety blood, and maybe in our countries, in the developing countries, we have problems to have enough sometimes, and this is an additional benefit. So this is the reason that the World Health Organization choose the effective implementation of patient blood management of one of the 6 strategies objectives for the framework for the 2020 to 2023. But there is a limited implementation of PVM in hospitals in the national health systems, and the question is why? I think that Arizanda explained that it's a change in culture, and this is one of the main points. It's a big challenge to introduce in all organization a strategy that is multidisciplinary and it's multimodal and involves a transformation of the organizational culture. And really has, he has said that really it's very difficult and to change the culture. And you know that for most of the professionals of the hospital, the transfusion or not transfusion is not an issue. They don't know really which is the impact of this strategies, this treatment in their outcomes. And this is this lack of aware is one of the important points to change behavior. And it's clearly that we have to be in line also for clinicians, managers, and regulators. So in 2014, we tried to find a method that allow hospitals and National Health Service to implement or to facilitate implementation of PVM program. We also want to assess the maturity of their PVM clinical practice, because normally most of the hospitals have some type of strategies introduced in some specialties. And we want to benchmark, to compare the different hospitals, identify the variability not only in transfusion but also in the PVM drivers, to know which are the drivers that we have to be more deeply, and also assess the continuous improvement of your clinical practice, not only in transfusion, related KPIs and the impact that these have in your outcomes. So, and also it's an additional advantage if you could ease the communication between the clinicians and the management of the hospital. Our philosophy is very old. If you cannot measure, you cannot improve it. This is what lead our project. So we developed this patient blood management maturity scorecard to serve the healthcare providers and also the healthcare service to implement, measure, assess, benchmark the respective PVM programs. And we designed this tool. And this tool is MAP. I say to you, maturity assessment model in patient blood management. This is not a new technology. You use maturity assessment model for other, but it's the first time that we use for studying the patient blood management. And the acronymus, that is MAP, you can see that really, it's really the map. You can see the blood, the drop blood, and also inside the erythrocyte. But you recognize that it's very, very similar to the sign of the Google Maps, no? Because really, MAP is the map of the PVM in your own institution. So what we want to know is where we are. So we analyze, we study, we have methodology to assess about what you are doing, how far you can go, because we benchmark the activity so we can compare and to know how far we can go, and also which are the steps that we need to improve, and this is clinical management, and this is what MAP offers to the clinicians and the hospitals. And this is the tool. I don't know if it works, maybe. You can recognize really that it's very similar to the Donemevian methodology. You analyze your structure, you analyze the process, and you analyze and you have results in the outcomes. So this matrix summarize your own practice in these dots, no? And you know where you are, and you can compare it to the others, or you can compare your practice in time, no? Your practice now and after you improve your strategies in PVM in your institution. And we analyze one complete year of the most bleeding clinical procedures that consume most of the bleed in your hospital, that are hip and knee replacement, colorectal cancer surgery, valve replacement, but also some type, not only elective surgery, hip fracture consume a lot, and you can do some type of PVM in this procedure, and also this is a change in the culture. It's not only for elective surgery. PVM starts in the elective surgery, but you can apply. It's a change in the culture in your hospital, but also for gastrointestinal bleeding that really consume a lot of blood, you can do PVM. And with that, we give to the hospitals a report of their own results. And if it's not the first time, you have also your dates from the year before, and also you have the norm to compare your result with the norm of all the hospitals participants in this edition. No, we perform a benchmarking every year, comparing the hospitals and discussing about the results, anonymized, but you can discuss about that. And also we have a lot of data during this last 6 years. So now belong to this research institute that is in MIM, so we can make some research and look for evidence about the implementation of PVM and the impact in the outcomes. So according to the structure, we make a web-based questionnaire and survey, trying to know what's about the majority of your organization in a structure. If you have a PVM group, if you have some protocols that are really all the people knows about in your institution. which is the awareness or the knowledge about PBM of all the professionals in your institution. So the key leader sent a very short internal survey that you can answer in 1 minute for all the professionals to know if they are aware, if they know something about patient blood management and about the transfusion and the risks or the impact in the outcomes. And also about the information that every clinician receive, if you can really check about if you treat or how many patients arrive anemic to the procedure, how many patients are transfused in this procedure, etc. But and according to that, you can see that these are the hospitals that participate in the last edition last year, and you can see that there are hospitals that are really very low maturity in practice, and there are some that really have a very high maturity. But the most important thing that you can take from this tool is the process, the analysis of the process that is according to the 3 pillars of PBM. We have some process KPIs from each pillar, and we extract all the data for this process, these procedures, from the electronic medical records from the hospital. This is one of examples what we can get. This is one of the KPIs of the pillar 1, only to see that really we can take how many patients are treated before surgery, and you can see that this is the benchmarking of hospitals, no? So there are a large variability, and you can see that if the main of the anemia treatment for total hip replacement is 12, there are 25 hospitals that treat over 25%, almost 50%, but there are more than 25 hospitals participants that never treat preparative anemia. And this is the same for colorectal cancer and cardiovascular surgery. And this really have an impact. This is another way to see the results in the benchmarking, and you can see the hospital 13 on the right side really treat almost 60% of the patients that are anemic. So really, you can see that there are few patients that arrive anemic to the procedure. Contrary, if you take a look in the hospital 4 that normally no treat preparative anemia, the patients arrive, this is the highest one, many patients over 70% are anemic when they arrive to the procedure. And the variability you can see in each driver, and this is very clear that we have to use, because the evidence is very strong of the use of antifibrinolytics for hip and knee replacement and cardiovascular surgery. And you can see that really the large variability in the practice of the different hospitals. And also in the 3 pillar, it seems that it's thin, but we are talking about 1 point for the transfusion, the hemoglobin level prior to transfusion, and there are hospitals that the mean in total hip replacement is over 9, and there are hospitals that it's 7. And this means a lot of transfusions. So the important thing is how this impact in the outcomes. So we measure the impact in the outcomes that are transfusion rate and consume, and also the hard outcomes that are morbidity, mortality, length of stay, and readmissions. And you can see also the variability in transfusion rate for each process, and the differences for the hospitals. This is random patients. Are 20. You can see the variability is the more large is in cardiovascular surgery, but also it's very high in each procedure that we analyze. And this is not neutral. Really, after adjusted you can see that have an impact in length of stay for each procedure, for intra-hospital mortality, for complications, and also for admissions. Our tool starts in January to May, that we recruit the new hospitals, and they sign the agreement with the manager of the hospital, and this is very important because the manager of the hospital is involved and receives the report of the results of 1 year. In May, we make a kickoff session to inform the new hospitals about the tool, but also the improvements of this tool, because we have a very close community of key leaders of the different hospitals that normally participate every year and try to improve, incorporate the maybe new procedures and also new indicators. And this is an improving tool. And also, from June to September, we collect all the data from the database platform and also the web-based questionnaire and survey. And in November, in 15 days, we are going to have the benchmarking meeting with all the hospitals participants to analyze the results globally. At the end, in December, each hospital received the report of their own hospital. And this is how it looks, more or less, the report. It's only to show you that really you know which is the data of your hospital and which is the norm, and if you are better than the norm and if you are worse or equal to the norm. So you know where you have to improve in which procedure, because you have this for each procedure. So you can show the results to all the team, and this is very powerful, because you think that really you do really in the best way, but when you measure your practice and you compare to the others, you know really that you can really be better. So I think this is the powerful of this tool, and it's the reason that we start really in 2014 with the design, and we take a look about the feasibility with very few hospitals, but the last yesterday, after 6 years of experience, most of the hospitals repeated. It was more than 60 hospitals involved in this project, and we have more than 200,000 procedures analyzed. So the hospitals are from different parts of Spain, of different size. They are public and also private, and teaching, no teaching. So what we have learned during these years, that really we can translate the clinical recommendations and the PVM best practice into a set of measurable KPIs. We can measure our activity. Second point, this tool really makes easier for the hospital to measure and benchmark the PVM clinical practice and outcomes. And also, we have seen that really it's feasible in a large and a growing number of hospitals to improving your implementation in PVM. Most of the hospitals measure their activity year by year and know which are the improvings, and there is an award for that, and there are many hospitals that can show an improving in the PVM implementation. So MAP provides hospital also a continuous care to evaluate your PVM performance and impact in the outcomes. I think it's clear which are the benefits for the hospitals, and we have clear that there are some additional benefits that you have really an insight in this topic, and also we increases knowledge. We are starting to make some papers with our data, so we are not increasing the knowledge about the impact of PVM, of the improving PVM in the outcomes. That could be very interesting. We have a very strong networking, and this is important to interchange experience, and because it's very powerful also. If you can listen to the others, how they improve some KPI or some driver. I say to you that really we do an innovation tool because we introduce modification year by year, trying to improve our tool. So now we start with international collaboration with Australia, that are the leads in PVM, but also with Germany. And we think that we have really a very good tool. We are very proud about this tool. And if you want to know about this tool and this methodology, you have the paper in the blood transfusion that was published last year. But really, we think that this is useful for the healthcare organization for implement, but also develop your own PVM programs and to improve safety and patients' outcomes. Thank you very much for your attention. So we have at least 12 minutes for questions from the audience, and I check if there is someone that online could make some question. Or at least one comment from the table, if you want to start.
Go ahead, Axel. Yeah, probably make it a bit interactive, and I want to ask the audience, who has heard the first time ever about patient blood management in that room today? Please raise your hand. 1, 2, 3. Okay.
We don't know online because.
Yeah. And probably I can also ask the audience, could you imagine in your hospital that this approach has a potential to be implemented? Any comment from your side? From those who raised their hands.
Yeah. This boy.
Can you give him a microphone?
Can you give the microphone to this?
Thank you. Well, I'm only a PhD candidate at my hospital, so I'm not too well aware of the blood transfusion practice at my hospital, so I'm afraid I can't say too much about that, so sorry for that.
No, it's okay, but this is probably something to encourage, that you all go back into your institution and get the data, the numbers from the blood bank. And as I said in my presentation, you will find out, if you compile the data, the transfused anemic bleeding patient is a loss leader. And when you have DRG systems, diagnosed related group, which is the reimbursement system in many of the, at least Western hemisphere hospitals, you will see that you lose tons of money with these patients, and the data show you that with patient blood management you can preempt this and turn the red into a positive number per patient, and this really accumulates not to not hundreds of thousands, but even on each institution, as I've also shown, it's millions. And the beauty is you have a return of investment in the first year. So even if you have entered a new budget period and your medical director says, okay, let's do this, and your quality and safety officers says, let's do this, we shift the resources, for instance, from the blood bank towards a patient blood management initiative, you will see a bigger bang for the dollar in the same year. And this is a unique situation that shouldn't hold up anyone to implement it ASAP. And this is why the WHO says urgent, urgent, urgent.
So I guess because there's such a large number of questions, I'll interrupt and make a comment. I think we try to impress the audience with the fact that no matter where you turn in terms of improvement of quality, value, as well as patient safety, you can always turn to patient blood management, where you cannot always turn to the process that we call the status quo, which is transfusion medicine. So I think that's one comment I wanted to address, but the second one is, let's bring it to today's real situation, which is all of us have been suffering from this pandemic, the COVID-19. And I think that almost every Western country has been claiming that there is a blood shortage, mostly because donors are not there to donate blood. And the constant call for blood donation is one where it actually leads to blood wastage. Blood is, again, perishable. It's a perishable commodity. It only has red cells 42 days, but if you go to, again, platelets, we're counting in single days. And the fact of the matter is that we're not looking at the use side, and what's happened in Spain to the use side has dropped considerably during COVID times. And all the blood that's being donated, at least data from US and UK, substantial amount of the blood gets wasted. Now, if we addressed our care in terms of going down to why we need that blood and actually looking at it from a point of patient blood management, where we could prevent the blood loss and also manage the patient's own blood, the perception of the need for blood, as we have with COVID-19, would change. But we are, again, doing the same thing over and over again, expecting different results. Donors are not going to come, and when they do, and they're not stable donors, most of that blood gets rejected because we find they have diseases which put them outside the donor realm. So this brings you to real-world situation where, again, patient blood management has only positive impact, and transfusions clearly, which is the current status quo, are again either wasteful, expensive, or again we're asking for change that is not going to come. There's always going to be a reduction, or we're always fighting to get more donors, mostly again to support the inventory, not necessarily to support the care of patients.
Doctora Basora?
Hello, I have a question for all of you. I am asking, what is the next step to implement PBM in the hospitals? Because clinicians have to trust in PBM to advance, to implement. So it's the transfusion committee, because all hospitals have a transfusion committee is regulated by law. But sometimes they are not very interested to implement PBM. It depends. For example, the quality services, in fact, they are more interested to have a good quality score than implement the health value
Practice.
health value care. So, in your opinion, who is the
Next step.
the leader?
Can we start?
Yeah.
Or
Go
You
first.
can-
Sure. What's that?
We
Go
can,
first.
All of the above, including you.
Yes.
So let me say this. Again, Joint Commission has come to Spain, has been in Spain, and they require you to review blood transfusion. And my recommendation is use the structure you have. And if you look at the blood utilization committee or the blood committee or the transfusion committee, they all have different names. We started with our transfusion committee in my hospital, and within a few years we changed it to be the patient blood management committee. And we added a pharmacist to it, because pharmacy is over here, the blood bank is over here, the patient is in the middle, but they don't know each other. So we improve on the process. It's very important to use the current structure you have and to infiltrate that structure with people like you who, again, will promote patient blood management. Even they're not interested, they can't stay at the current status quo because patient blood management is knocking at the door and they need someone to, again, show them the road. In addition to that, in this particular conference, it's so important to reach what we call the C-suite as clinicians, right? The leadership of the hospital, because the leadership of the hospital will definitely make a push in terms of showing that management is a value that needs to be in our hospital. So we need to get to them. So it's not one individual, it's not one structure. I think it's all of that. But again, it depends also on the culture of the hospital. If you don't have the hospital leadership involved, the likelihood of it succeeding, no matter who is the next person pushing, is going to be much lower than it succeeding if the hospital leadership is behind it. They don't have to be in front of it, but they need to be behind it. So that's who I would approach and use the structure that's there in the hospital to infiltrate that.
Mm-hmm.
Time, we're here not to change things in urgent doesn't mean tomorrow. Urgent means that you cannot live without it, right? You need to have it, versus it has to be done tomorrow. This takes time and it takes resilience.
And if I may add to this, what Ari just described is a very good bottom-up approach. We had the good situation, we were lucky, the fortunate situation in Western Australia that the medical director of the state of Western Australia, so basically a public health authority, understood the importance of patient blood management. He is by training a intensive care specialist and anesthetist. And as the chief medical officer of Western Australia, he basically engaged the entire hospital system, including the IT department, including all the administrators, all the pharmacies. So we had a clinical group of experts of 89 or 88 department heads to begin with. And of course this included also the transfusion committees. They don't exist anymore. We have only patient blood management committees now. And in these committees we have a multidisciplinary representation. And and I encourage everyone in the room, please download the WHO policy brief, because at the end of the policy brief there's a call to action for all member states of the World Health Organization that they first of all should organize governance. So this is basically your question, and you don't need to wait until your provincial government organizes governance to do this, let's say in Catalonia, but you can start as a hospital. But you should really look for a dialogue with the health authorities of your state, of your country, of your governments, of your federal bodies, to let them know it's now time to do something bottom up and top down.
Yeah. So we are really on time. So if there's no other question, we are going to finish. And thank you very much for being here and this interesting